What are the next steps, let's say, for a patient who has 3 + 4 = 7? They have this conversation with their doctor, they do some research, hopefully on their own. What's the next steps to deciding treatment?
Well, first, I think before you get there, if someone has had a biopsy and an MRI, the next step is to match up the information. When the doctor does the biopsy, it'll say it's in this particular region of the prostate. And then you can go to the MRI and you can look at where the lesion is, the spot, and see if those match. Is it on the left side toward the top of the gland for the biopsy? And is it on the left side toward the top of the gland for the MRI? If a patient has a biopsy that's positive on the left and an MRI showing a spot on the right, one has to wonder if the spot on the right was missed in the random biopsy. And that patient may need further evaluation to find out if he has 2 tumors and if the second tumor might even be a higher grade. So it's important to have precision and good, clear understanding before you get into that next step, which is to decide what to do. And there's so much variety depending on, is it unilateral, bilateral, is the tumor large or small, and all these other factors are going to drive the decision-making process.
So in that scenario, if there is a tumor that was missed, let's say on the right side from the random needle biopsy, do you suggest that with the imaging they get a targeted biopsy in order just to take 1 or 2 needles and take the tissue out? Can you explain targeted biopsy versus random needle biopsy? Because I don't think a lot of patients realize that they can have that as a secondary confirmation.
Right, so that random biopsies, they do a grid pattern and then they just stick needles, usually a dozen needles throughout the gland. And the targeted biopsies, they use imaging as a guide. In other words, if there's a spot in the upper right-hand corner, then a needle is poked in the upper right-hand corner to see what the grade is of that spot. And the targeted biopsies are picking up in popularity very quickly now. It's been a while. They've been out for more than 5 years, but the literature and the urologic community is starting to acknowledge that these are better than random biopsies. This is such a sensitive area of the body, and men value their capacity to get erections and perform sexually so highly that if people can get good, precise information about where the tumor is, there's always a possibility that they can just treat a section of the prostate. A lot of people don't realize that the standard of the industry is to treat the whole gland, just to be safe. And that was necessary when we didn't have imaging to make sure that the cancer was totally eradicated. But now we've got good imaging. We can determine where the tumor is, and with skillful doctors, the possibility of just treating a section of the prostate becomes available, and then that reduces the chance of a man becoming impotent from therapy.
So those are some really good points. I think that one of the things that comes up often in conversations with patients is the anxiety of having to wait to not jump to treatment and make sure that everything is done properly, that they've taken a look at what type of cancer they have, the imaging has been done, and if anything else needs to get a targeted biopsy. Can you speak as to why it's okay to wait? Prostate cancer is slow growing. I feel like when patients hear that, they're like, well, how can you say that? It's cancer. And I know we've talked in the past about the scary C word. So can you explain why it's slow growing in these cases and why it's okay to take your time and decide on treatment?
Yeah, it's hard to deal with fear. I mean, we're all nervous about this virus situation, and the rational discussion doesn't always help people get clarity, but sometimes it helps to let people know that the tumor that is being dealt with now, say in this year, probably started 5 to 10 years ago and took this long to get big enough to be detected. And so since we're playing for such high stakes, and precision treatment will lead to much better outcomes, better cure rates, and less side effects, taking a few additional months to get it right makes perfect sense. And there have been a number of studies looking at popular surgeons who have long waiting lists, and patients have had to wait up to 6 months to get the right doctor to do their radical prostatectomy. And then those doctors have gone back and looked at the cure rates of the patients that waited 6 months versus the ones that had immediate treatment. There was no difference in cure rates.
then the mindset, I would think, really needs to change for the patient of quality of life and what type of side effects that they're willing to deal with in the meantime. So can you talk about that? Because I don't think patients realize that the choices that they're making with prostate cancer lasting, being more of a chronic disease, I don't think patients realize that the side effects are really what they're going to be living with on a daily basis. The fear may dissipate, they may feel comfortable, but that's a huge factor.
Yeah, this is something that's actually true with all types of prostate cancer because the prostate's located in such a sensitive area of the body, which can affect, people are going to the bathroom all day long and they're going to be reminded every day for the rest of their life if that doesn't work properly. Sexual activity can be irreversibly changed. So that, and people live a real long time with prostate cancer regardless of how serious the cancer is. So all of this needs a sort of a repositioning of the way people think about prostate cancer. This attitude would be irresponsible if we were talking about lung cancer or colon cancer, where if you don't win the battle on the first go-round and cure it, those people will go on and die of the disease. Prostate cancer, you get a second chance, a third chance to cure it, and then even if you don't cure it on the third try, you can control it for 10 to 20 years with hormone treatment. So it's a totally different type of situation compared to most cancers.
Thanks for watching. If you would like more information about the topics we discussed today, you can go ahead and visit our website at PCRI.org. Don't forget to subscribe to our YouTube channel. We come out with new videos every single week.